Hello, everyone, and welcome to Chapter 9 Pharmacology Lecture, and Coagulants and Anticoagulants, Medications that Affect Coagulation. So let's get started and talk about vocabulary first. A lot of individuals get confused with hemostatics, anticoagulants, and thrombolytics. These are three words that you absolutely have to know the definition of. You will hear them in your OR frequently, and you need to understand what they mean and what people are talking about. Hemostatics. Hemostatics stop the bleeding by helping to form clots. So they are going to help the blood clot either naturally on its own, or they're going to incentivize the blood to stop bleeding. These are almost always topical agents. When we talk about hemostatics, they're usually something we put on top of the bleeders so that the bleeders will stop. Then we have anticoagulants. Anticoagulants are the opposite of hemostatics in the fact that they prevent clotting. They're going to keep the blood in liquid form. So patient's blood is thinner. It's not going to clot as easily. It's got a lot more liquid in it than it does red blood cells and platelets. So that is how anticoagulants prevent clotting. People that are on therapeutic anticoagulants that are on chronic blood thinners need to make sure that they stop those blood thinners at least 1 week before surgery. Otherwise, they can't clot appropriately, and so they have a better chance of losing a large amount of blood. And then there's thrombolytics. Thrombolytics break down clots that are already formed. So when a clot is already formed and we want to break it down, say that you have a clot somewhere in your body, femur or iliac branches, that we want to break down that clot naturally, we're going to prescribe thrombolytics and see if we can get that clot to dissolve on its own, because we want our own body to dissolve that clot if possible. All right, so let's do a quick review of how do blood clots form. So stage 1 is that we have thromboplastin is formed. Thromboplastin is a precursor to thrombin, and thrombin is our coagulant. So thromboplastin is formed. Thromboplastin then converts prothrombin to thrombin. So I'm sorry, thromboplastin is not a precursor. It is the enzyme that converts prothrombin to thrombin. Once thrombin is converted, thrombin is then the enzyme that is going to convert fibrinogen to fibrin. And fibrin is the substance that forms the net for the platelets to cling to begin forming the clot. Now, there are two pathways for this to happen. There's the intrinsic pathway, which is what happens when a vessel is damaged naturally. We fall and the vessel gets damaged underneath, there's bruising. The extrinsic pathway, though, is what happens when we are cut. So when we cut into our patients, we are actually having them clot through the extrinsic pathway. The extrinsic pathway happens because we are usually bleeding a lot more than when we just fall and bruise. And so we need to get those clots formed a little bit faster. So the extrinsic pathway is a little bit faster. The intrinsic pathway is a little slower. However, both pathways require calcium and vitamin K to be able to function appropriately. So those are two important minerals that you need to know about for the rest of this chapter. So as always, I learn better from a picture. So we have our skin that gets cut. First thing that's going to happen is we have some vasoconstriction. The vessel is going to clamp down on itself. Platelets begin to aggregate because thromboplastin here starts to make prothrombin, and then the prothrombin makes the thrombin. It then converts the fibrinogen to fibrin, and then we start our clotting process. And as we clot, if we go the extrinsic pathway, we have clotting factor 7, calcium and vitamin K. It doesn't show vitamin K in here, but vitamin K is important. If we do the intrinsic pathway, we have clotting factors 8, 9, 10, 11, and 12. And so it just depends on which clotting factors we call in and how quickly we build that clot. And this cycle is going to continue until we have a clot completely formed. Once the clot is completely formed, then we're going to, the clot is going to retract, so it's going to pull the skin edges together, the vessel edges together, sorry, not necessarily skin, the vessel edges together. And once those vessel edges are together and healed, then we have fibrinolysis. And what fibrinolysis does is it destroys the fibrin in the clot. And the fibrin in the clot then becomes destroyed, and then those platelets are released and usually destroyed by the liver as they circulate through the body. So I hope this helps kind of understand how clots are formed and destroyed in the normal process. So let's talk about hemostatics. Topical agents that are used almost exclusively in surgery. We don't use hemostatics an awful lot on the floor or in a doctor's office. We have several kinds, but their most common are absorbable gelatin, microfibrillar collagen, oxidized cellulose, absorbable collagen, sponges, and then thrombin. So absorbable gelatin. It's a mechanical hemostatic. Remember that we have hemostatics in three forms. We have mechanical, we have chemical, and we have, oh my gosh, I just went blank. I'm sorry, we're going to talk about all of them though. But this is a mechanical hemostatic. So this would be something like gel foam. And so this just provides a matrix for the blood clot to start forming on. So it just creates a ladder, if you will, a net to catch all those platelets so that the blood clots can start forming inside of the body. Absorbable gelatin is usually completely absorbed by the body in 4 to 6 weeks. We have absorbable collagen sponges. These are usually made out of bovine collagen. Once again, this is a mechanical method of action that we put this on the wound, and this provides a matrix for those platelets to grab onto and start forming the clot. We have microfibrillar collagen hemostat, once again, made from bovine. It's a mechanical method. It's the same kind of collagen hemostat, except that we've kind of shredded it up so it's nice and tiny, has lots of tiny little holes, and it's a little softer to touch than just the regular collagen hemostat. And once again, a mechanical method of clotting just provides a matrix for those platelets to grab onto. Oxidized cellulose, we take cellulose from plants. Sometimes these can be bactericidal. We put some antibiotics in there, and then these usually need to be removed. The body doesn't naturally dissolve cellulose. However, there is some products now that are using cellulose that can be absorbed by the body. But generally we remove these unless the packaging or the surgeon says otherwise. And then of course, last but not least, is our thrombin. It's made by our recombinant DNA methods. And this is a natural enzyme that we have occurring in all of our bodies. So what we're going to do is we're going to reconstitute this with, usually it comes in a package with sodium chloride and the thrombin, and it's got this something like this that will hook these two vials together. You put this on here, you drain the sodium chloride into the thrombin, and then you mix the thrombin, you shake it up after all the sodium chloride is there, and then you'll have your thrombin. Notice on your thrombin it says for topical use only, do not inject. Make sure that you are not putting this in a syringe. It only goes in a petri dish, just like our concentrated epinephrine. We do not want to inject topical thrombin. So if we do, it can cause systemic clotting, which then leads, of course, to our patient having serious complications and possibly death. What we want to do is just create that clotting cascade in the immediate area of the bleeding. And then we have bone wax. Bone wax is made from beeswax, and we don't use bone wax as often as we used to, but basically you would just rub this on the bone and it would create a mechanical barrier so that the blood couldn't seep out of the bone. It just was a plug as opposed to actually providing that matrix for the clot formation. This was just like putting a plug on top of the vessel so that the bleeding couldn't occur. Chemical hemostatics. These usually interact with mucous membranes and specifically the water in the mucous membranes. These are silver nitrate sticks. They've been used, but they look like unused matches when you receive them onto your sterile field. You put them onto the mucous membrane. Usually these are done in gynecology. And after we take the tenaculum off the cervix, those two little poke holes where the tenaculum was can bleed, and so we will get a silver nitrate stick and just put it right on top of where the bleeding is, and it will create a heat effect and cauterize that area and stop the bleeding. So our review questions: name 3 types of hemostatics. Know what thrombin does, where is it placed in the clotting pathways, and what is the difference between the intrinsic and extrinsic pathways. All right, now we're going to talk about systemic coagulants, things that we can give to the patient IV that will cause clotting throughout their body, but specifically in the area that we want it to. But these are things that the patient's usually lacking so that their clotting cascade isn't working appropriately. Our systemic coagulants are calcium salts, vitamin K. We can give just clotting factors, and we can give just factor IX complex. And remember, factor IX complex is used in that intrinsic pathway. So calcium salts, we saw that calcium is needed for normal clotting function. Sometimes when we're giving blood transfusions, blood calcium may become low because we don't usually transfuse calcium. We don't put calcium into our blood products. So when we're doing our blood transfusions, we need to really watch the calcium levels. And anesthesia will monitor the blood calcium, and they will inject calcium chloride if needed so that we can make sure that our patient's calcium is up where it needs to be. If we know that our patient has a clotting problem, we may give calcium preoperatively, either with a tablet or an intramuscular injection before they come back for surgery. Vitamin K. Vitamin K is a fat-soluble vitamin. Why do we care about that? A fat-soluble vitamin will be taken up into the fatty tissue of the patient, and it can be toxic if given in large doses. So if we give too much vitamin K, we can actually poison our patient because the body is not flushing vitamin K out into the urine when it has enough. It is continuing to store that substance in the patient's body. Vitamin K actually increases the production of clotting factors that are available in the blood. So this helps in the intrinsic and extrinsic pathways. Patients on blood thinners may be deficient in vitamin K. So this is one of those things that if we know our patient has been on blood thinners for a very long time, we may check a vitamin K preoperatively and then start them on vitamin K therapy before they come to surgery. Now, vitamin K therapy is not instantaneous, so we can't just inject large doses of vitamin K. Once again, that fat-soluble vitamin, we can really harm our patient. So if we need instantaneous vitamin K, then we transfuse fresh frozen plasma, not just the red blood cells. And also be aware that IV vitamin K may cause anaphylaxis in some patients. Not really sure why that happens, but it can. So we want to make sure that we're being very diligent when we're doing our vitamin K and assessing our patient if we have to do vitamin K IV in the OR. All right, blood clotting factors. These are most likely used in patients with hemophilia, and factor IX complex is the most commonly used. We get factor IX complex by drying out plasma and then separating out the factor IX complex. This is usually administered IV right before surgery and then as needed during the surgery. Most of our patients that have hemophilia we know beforehand, and so They have been on other therapies to help their coagulation factors, and then we give them factor 9 kind of as um, a an insurance policy that our patients will be able to clot and to heal appropriately after surgery. So our review questions for systemic anticoagulants, list two of them. When is factor 9 complex most commonly used, and why is vitamin K not given intravenously? All right, heparin. Heparin is the anticoagulant that we're going to learn about. Remember, anticoagulant means that it's going to prevent clot formation. So it's not helping the blood clot. It's not helping the blood to unclot after it has a clot. This is preventing the clot from forming in the first place. Heparin can act in several ways. In the clotting cascade, it can bind factor 10, so it interferes with the conversion of prothrombin to thrombin, and it actually inactivates thrombin. So heparin is kind of the counter opposite to thrombin. So heparin is going to bind to the thrombin and make sure that the thrombin can't convert that fibrinogen to fibrin, creating that net for the platelets to be able to hold on to. Heparin is always measured in units, and there are several doses. You may give heparin 5 units per mil. You can give heparin 50 units per mil. So make sure that you label everything clearly. And this is mainly used in the operating room for vascular procedures. So when we're working on those vessels, we want to make sure that the blood isn't clotting inside the vessels as we're working on them. So we usually give some heparin right inside those vessels and around the area to ensure that there's lots of good blood coming out of those vessels. It's not clotting up on its own through the extrinsic pathway. All right, heparin. One thing we need to know about heparin, it is inactivated by protamine sulfate. Why is this important? Because heparin obviously causes our patients to bleed. And so if we were to, one, accidentally give too much heparin, but also at the end of the procedure, we want the patient's blood to kind of start being able to use that clotting mechanism again, we can give protamine sulfate, and protamine sulfate will bind to heparin and keep it from binding to thrombin, which then allows our clotting cascade to continue and work normally. Protamine sulfate is not something you will have on your back table. This is given by anesthesia, IV to the patient. So when the surgeon is done with surgery, they will let the anesthesiologist know that it is okay to give the protamine sulfate. There are lower molecular weight heparins. They're used the same as regular heparin, although they're not as easily reversed by the protamine sulfate. So we generally don't use these inside the operating room. You should know about them, but they're more the things that patients use as chronic blood thinners. So that's one of those situations of why we need our patients off of their anticoagulants at least 1 week before they come for surgery, is because they're not easily reversed. So we want to make sure that most of that heparin is out of their body before they come to surgery. Then we have oral anticoagulants. Once again, these are used for long-term management. Oral coagulants, especially for DVT, deep venous thrombosis, and PEs, which means pulmonary embolism. We use a lot of coumarin derivatives, which common name is Coumadin, is the brand name for that medication. And coumarin derivatives work by inhibiting vitamin K activity. So they bind up to vitamin K, which then inhibits both the intrinsic and extrinsic pathways of clotting. And then, of course, aspirin is an oral anticoagulant. We don't want our patients on aspirin either. And aspirin works by inhibiting platelet aggregation. It actually kind of coats the platelets and makes them slippery and makes it so that they can't grab onto those nets. All right, now let's talk about thrombolytics. Thrombolytics are drugs that dissolve the clot. So once the clot is formed, the thrombolytic can go in and destroy the clot. These drugs are given intravenously. We don't usually use these a lot in surgery. These are therapies that we try to use to prevent surgery, honestly. But the drugs will activate plasminogen. And remember that plasminogen is what forms plasmin, and plasmin digests the fibrin in the clot, so the clot breaks apart. We use these drugs when treating acute myocardial infarctions or heart attacks. They are used to treat DVT. They can be used to sometimes treat pulmonary embolisms. It just depends on how big the pulmonary embolism is and if we feel surgery is a better option for that patient. But thrombolytics we try to use as much as we can to dissolve the clot before we have to do surgery on the patient. So our review questions are: what is the mechanism of action of heparin? What is the reversal agent of heparin? And how are oral anticoagulants used and for what purpose? I hope this helps you have a better understanding of this chapter. I will talk to you soon. Have a great week.